Okay, all right. No, we're not going to say much, but I mean, we just want to basically introduce the session so everyone knows roughly kind of how things are going to work for today. So obviously these networking events are just an opportunity really for clinicians to get together with researchers and have quite an informal opportunity to hear about what they're working on and to then talk and ask questions and things like that. So it's really for all of you. And so we've got 4 speakers lined up. And we're going to try and keep them to time. So it'll be 12 minutes talks, and then we'll have a short bit of time for questions after each of the talks. But then the idea is at the end of that, so we're going to ask all of our speakers to basically spread out around the room. You could probably all stay in here, I would have thought. So, and then it's just if anyone wants to go and ask any questions or talk in more detail, then it's just a very kind of relaxed opportunity to talk more with the researchers who are presenting their results. Brilliant. Okay, so to kick us off, let me open up the first talk. Alrighty-o. So we're going to hand over first to David Baur, I'm going to pronounce your name wrong. Baur, I should have checked with you before. So David's going to talk to us about investigating the role of the corticospinal and reticulospinal tracts in upper limb paresis in chronic stroke. Thanks, David. Okay.
Okay, yes, so thank you very much for the opportunity to present my project here to you. I'm working in upper limb paresis in chronic stroke, and as we all know from our clinical experience, they can be quite variable between patients. This is not only in the severity, so from mild to more severely impaired, but there seem to be also specific components or subcomponents of paresis, and making the treatment actually a great challenge. And so some of the components we observe is, for example, motor control, the fine coordination of muscle activity, or there's strength, there's spasticity or flexor synergies, so the involuntary activation of flexor muscles, involuntary co-activation of flexor muscles. And these different components seem to be really separatable from each other, which was, for example, demonstrated in this study. So in this study, the researchers were following up the spontaneous recovery, motor recovery from 1 week after stroke until 1 year. And what they saw was the motor control was actually improving in the first 5 weeks, and then it was plateauing, nothing much anymore happening, whereas the strength was improving over half a year or almost a year. These two components were quite separatable after the stroke, which points to the direction that they might be mediated, or there might be different neural substrates underlying for these different components. And the current framework for paresis after stroke is that the clinical picture that we see is actually dominated by the damage sustained by the corticospinal tract and the resulting upregulation of the reticulospinal tract. So the corticospinal tract, which can be seen here on the left side, is the main motor output tract in humans, and it is highly unilateral, so damage to it has devastating consequences. Whereas the reticulospinal tract is a phylogenetically older system, and it is more bilaterally organized. So that means if we have a lesion here, there are still inputs from the other hemisphere that kind of can deliver activation to the system and to the affected limb. Now, what studies in animals have shown to us is that when there is severe damage to the corticospinal tract, we see an upregulation of the reticulospinal tract happening. And some of these also, mostly from animal literature, we see that some of these different paresis components that we observe can actually be mapped onto this tract. So the motor control seems to be mainly a function of the corticospinal tract, whereas phenomena like spasticity and flexor synergies are more related or more associated with the reticulospinal tract. But like the main evidence for this actually comes from the animal literature, and these associations are more or less under-characterized in humans, and which is actually what I try to improve in my project. So in the project, what I'm currently working on is I try to bring together the clinical phenotype we can observe of upper limb paresis we can observe in stroke patients with the underlying neurophysiology. And the goal of this whole project is to see if we find associations and to see if we might find certain patterns of activation that could define subtypes of patients, and if we could identify such patterns or such subtypes, that would be kind of the first step for a more individualized therapy to these patients. But yeah, so what do I do in my current project or my current study? So on the one hand, I try to characterize the clinical phenotype of the chronic stroke patients as precisely as I can. So that means I test the motor control of the patients. I do this with this device, this so-called CNR device, which does kinematic assessments of motor control, and the patients, they have to do a visually guided reaching tasks. Then I measure the strength with dynamometry. I test spasticity with the modified Ashworth scale and also with the KINARM, so kinematic assessment. And I also perform the Fugl-Meyer assessment. So the Fugl-Meyer assessment, I think most of you know, is a score, a motor impairment score, but sub-scores of this assessment can also be used to quantify flexor synergies. So this is the clinical part, or the characterization of the clinical phenotype. And now the neurophysiology, or the activity of these two tracts, is assessed with TMS, transcranial magnetic stimulation. So if we give TMS pulses over the lesioned hemisphere, the fibers of the corticospinal tract are activated, and we can record responses in the affected limb, and these responses are then called the so-called contralateral MEPs. Now, what I do in my study is I classify patients in these two different groups. So when I get signals, or when I can elicit signals over the lesioned hemisphere, these patients are CMAP contralateral MEP positive, meaning they have partial damage to their corticospinal tract only. And if there are no responses at all, they're classified as CMAP negative, which means there's really severe damage to the corticospinal tract. Now, with TMS, if we stimulate over the contralesional hemisphere, meaning the healthy hemisphere that is not affected by the stroke, we can also elicit responses in the limb of the same side, and these responses are called ipsilateral MEPs. And they are thought to be a marker of the reticulospinal tract, or mediated mainly by the reticulospinal tract. And what I do here is that I apply these pulses in two different conditions. So one without any sound, and then also with a startling sound, so a very loud sound, more than 110 decibels. And it is thought that this startle sound achieves a direct activation of the reticulospinal system. So this is kind of a more fine-grained way than to test the excitability of the reticulospinal tract. Okay, then let's jump to the results I so far have obtained. So short disclaimer, it's still preliminary. So I so far have tested 49 chronic stroke patients. I think that's quite a good number already, but I wanted to achieve more than 50, so I'm very close. But at the moment, I'm also recruiting a healthy control group, so that's what I do mainly at the moment. And now, when we look at the results for the corticospinal tract, this is what we see. So down here, we have the CMAP positive and CMAP negative, so meaning a partial damage to the corticospinal tract and severe damage to the corticospinal tract. And here on the y-axis, we have our different components. So if we look at motor impairment, so the Vogel-Meyer scale in general, we see that those who have partial damage of the CST only are much less impaired compared to the patients with severe damage of the corticospinal tract. The same can be seen for motor control. So here, for the Vogel-Meyer assessment, the higher the score, the more motor function, or the better the motor performance. For motor control, it's the other way around. So the lower the score, the better the motor performance. And what we can also see here is that those with intact corticospinal tract have much better motor control. If we look at the strength, so this is the relative strength, meaning the strength of the affected limb normalized to the non-affected side. We see also that those with corticospinal tract or more corticospinal activity have more strength. And the same is what we find for spasticity, so the modified Ashworth scale, meaning a lower number means less spasticity. We actually see that those with a severe impairment or severe damage to the corticospinal tract are have much more spasticity. So if we summarize this, actually on every single item, the patients are have much greater deficit if they have severe corticospinal damage. And if we now look at the results from the reticulospinal tract, so we can see them here. And now on the y-axis, we see the IMAP presence. So for every condition, I give 16 pulses, and I just count in how many cases do I get a response. So if we look at that for the non-startling response, we see, okay, that's the percentage, and there is a significant increase in responses if we use the startle sound. So this is what we would have expected, that we have more activity with this additional input into the reticulospinal system. And this is kind of the expected result. Now, interestingly, when we separate the CMAP positive and CMAP negative patients, we don't see, at least currently, we don't see any statistical differences between these groups, which is actually we would have expected, because the idea or the theory is that we have a kind of strong upregulation with severe damage in the corticospinal tract. So at the moment, we don't see this. We see that there is a trend, right? So for the severe damage, this seems to be generally more presence in IMAPs, and also the increase with the startling seems to be higher. But so far this is a non-significant trend. And when we look at the IMAP area, so this is kind of really getting into the details now, but this is a different parameter how to measure this IMAPs or these responses over the contralesional hemisphere. We see the same results. So there's a significant increase in the area from the non-startle to startle condition, but no significant difference between the CMAP negative and the CMAP positive group. But I think what becomes very clear here is that there is actually a great variability in the responses in this measure. So we have some patients have responses as high as 45, and but the median is around 4. So there is a great variability, and it seems there is evidence that these responses are quite bigger or larger in younger participants. So this is still one of the aspects or things that I'm thinking about currently. I'm almost done. Sorry, thinking about currently how to integrate, for example, age in this analysis and what role it might play. But this brings me to my summary already. We see that in my data that the integrity of the CST is really crucial for all the different components of the paresis, and we see that startling acoustic stimulus also is able to excite the reticulospinal tract, but there is no difference between CMAP positive and negative patients. But at the moment, the results are still preliminary, and the patient recruitment and also especially the control group recruitment is ongoing, and it will be very exciting to see the relationship between these IMAP parameters and then the different paresis components. Okay, that's it. Thank you very much for your attention, and I'm looking forward for your questions.
Okay, yes, our first question, go for it.
Hi. Just a quick question. It's not really related to spasticity, but I still have a question. Because you were saying that the cortical spinal tract is predominantly involved in motor control. But if you go to your results, again, of the motor control bit with the KINAM, it's interesting that when you look at the CMAP negative or negative MEP, it's very bimodal. So you have like the upper bit and then you have the lower bit and then nothing really in between. So it seems like that even when you have quite a lesioned cortical spinal tract, some patients seem to be able to perform quite well on the visual guided reaching, whereas others seem to really fail at this task. So do you think you can support the statement of saying like cortical spinal tract, if it's lesioned, you don't have motor control anymore, or do you think that's compensation?
That's a very good question, and already, I think it gets into the nitty-gritty of this. So you're talking only about the motor control, or you were starting with the spasticity, but what you're interested in is the motor control? Yeah. I think what is very interesting here is that in this task, so for some of the very severely impaired patients, it was quite challenging to do this visually guided reaching task. So they could not reach to all of the target, which is also, I think, a result already, but those might be those that perform very poorly. But still, if we look only at those who actually can reach or who perform better, I think it is still clear that on average they perform worse than the other patients. So it might be that the difference is not so extreme, but I think overall this assumption holds. Yeah, that partial that the MEP positive patients perform much better in motor control task. Yeah.
Okay, thank you. Anyone else got a question for David? No. Okay. All right. Thank you very much, David.
Okay, last but certainly not least, we have Donnelly. He's a consultant neurologist here, over at the Royal Free, and Ella Rackeman. He's a community paediatrician over at Barnet, and they are presenting to us this evening on developing a transition pathway for young people with neurodisability, a pilot service evaluation from Barnet and Edgware. Thank you very much. Over to you.
Okay, so yes, this talk is about bridging the gap for children with neurodisability moving into adult services in our particular area. So before we did this, there was a gap in provision. There was always an epilepsy transition clinic, but there was no direct link between the paediatric and the adult services. That's a quote from the paediatricians, a bit of pot luck, what happened to them, where they ended up. And there was an ad hoc referral process to therapies, either from the school or from the community sort of paediatrician, but there wasn't a formal pathway. So
this is obviously a really busy slide, but it just shows you the amount of contacts that we would have for our patients. So this was an annual review for Down syndrome, so not necessarily motor disorders, but it can just show you that happens. That's what I do on an annual basis for every young person with Down syndrome right the way through to 18, and it's very similar to other complex needs. And as you know, when you're a community paediatrician, we don't seem to be able to see anyone over the age of 18 or 19 in full-time education. So there is a massive, massive gap and fallout from there, which is where the lovely Anne comes in.
Okay. And so what we've done, we've used an existing resource. We already had an MDT, which was consultant-led with an occupational therapist and physiotherapist. And we were seeing people with chronic neurodisability. And so we thought we will make contact with the paediatricians and see, is there a way that we can maybe meet the children and get to know them before they reach the age of 18, and maybe try to meet them where they are or meet them with the paediatricians, and try and get things going early so there's not sort of at the end of this school year a massive sort of flood of referrals. So this is me with Laura and Natalie, my colleagues. We're based at Edgware Neurorehabilitation Centre. This is Ella.
Yeah,
with
we're
her,
actually in the same building, which we only recently seem to have discovered. So that's been a massively positive addition. So actually we only have to walk across the car park, and there we go.
But I also work at Barnet and at the Royal Free, so I'm available in a number of spaces, and I can also do home visits for very severely disabled children and adults. So our patient group is complex neurodisability. They typically have to be a Barnet resident or have a Barnet GP for the MDT service, but for the neurology clinic in Barnet where I can see them, that's a wider sort of remit. We're not so strict on the 16 to 19 in that we will take them we will meet them a bit earlier. We may not take over, there may be an overlap with the paediatricians for a few years, but we will, we'll begin to get to know them as they're reaching that age. And then they often will already have a long-term relationship with the paediatric teams at the Royal Free and GOSH often. And often the families are very anxious and really reliant on the paediatricians. So
this we just wanted to show you because there was a map earlier as well of NCL. So this is just really showing you Barnet, which I think in the NCL is probably the most populated borough now. It's the second largest borough in London. I think Croydon's just pipped it in terms of population, but actually we're not the leafy rich suburb of NCL that I think has still is being, funders and commissioners believe. It's really changed, the dynamics changed, but unfortunately our staffing and resources hasn't, so we're really understaffed compared to the population we now serve, which is huge.
So we agreed when we first met with the paediatricians, and that includes the paediatric therapists, and obviously my colleagues are therapists, is to try to set up a pathway for local patients who are nearing transition and find the right pathway for each patient. So they don't all need to go to a specialist epilepsy clinic, or they don't need to all see the orthopaedic surgeons, and they don't even need to all see me, but we have a long-term conditions register. So whenever they move into adulthood, if they're fairly well with their cerebral palsy, we can keep an eye on them, because they will encounter difficulties with accessing work and different things like that, which we can help with. So we, if they're not sort of needing us urgently, they will be added to this register and they'll have an annual checkup. And then also there are paediatric referrals coming from the paediatric physiotherapists who do their sort of routine cerebral palsy assessments. And then we try to get in early to prevent the referral cluster. Another very busy slide.
Another very busy slide. So this is generally the kind of patient that we might be talking about and trying to transition in a much smoother way. But the child is at the centre, a young person. As I say, we do need to discharge at 18, 19 if they're full-time education. So we're hoping to start transition a lot earlier with Anne and her team. But transition is meant to start from 13, 14 years of age officially in terms of our the guidance that comes out from NICE and education. But it is not unusual that the most complex young person would be under 10 different specialties at Great Ormond Street Hospital that very rarely communicate with each other. So I'm going to put me at the centre of that as well, desperately trying to get information from several different computer systems that don't amalgamate with each other. So you can't just hand that over to the GP, which is currently, what often happens is you're just left to refer to a GP who hasn't built a relationship with these young people. So we need something better than that.
Okay, so I looked at the NICE guidelines for transition and also for cerebral palsy and where they overlapped. So thanks to AI for that. And so young person-centred care, early planning, an MDT approach, involving the families and carers, continuity of care. So I'm an adult neurologist, so I won't discharge them. And information and advocacy, supporting their independence. So luckily at Barnet we have a very well-staffed vocational rehabilitation service. So that's really feeds well into supporting them into adulthood, and then also post-transition support, which would be me and my colleagues. So generally people refer us from lots of different routes via directly to us in my MDT via therapy or paediatrics. GPs can refer to general neurology. Often they're seeing both. And then we're now having regular meetings where we meet up with the paediatrician to say who's about to graduate in the next 12 months and can we sort of begin to see them sort of pace it over the year. And so we've seen approximately 12 to 15 in the first MDT clinic. Some have been seen more than once. Often they'll need interventions like help with wheelchairs or some physiotherapy. Some are directed to a general neurologist or a therapist-only programme, depending on their need. And after an initial assessment, we will often do a therapeutic follow-up, often at home. One person had been admitted for inpatient rehab. They've all joined the long-term conditions register and I see them all annually. So what has been better?
I can tell you what's been better, yeah. I think this first quote is really important, that parents are terrified for years about the drop-off when they go into adult care and they fear it. This comes up all the time. It just feels like a real abyss to them. So this has just created something that is much more held, much more contained, and much more, we're able to actually just kind of go through that process with them rather than them feeling that they've just dropped off a cliff. It just feels a lot more organised, like having, someone we can talk to about what we're going to do with this family and this young person, and have just much more realistic goals for them and pathways. So it's been really appreciated by us. And what could be improved. So there's still some bits that, this is early days. We started a year ago or something. So, it's early days, but, we definitely could make things a little bit more joined up with therapy to therapy referrals. We'd like that to be a bit more joined up. And just something I noticed recently, which not necessarily related to our pathway, but I do have young people who would definitely have been accepted by the Children's Hospice for symptom care, respite care, who do not at all get accepted by the North London Hospice. And I don't know how to sort of bridge that, but again, that's just something that I've noticed and we've talked about. Things we just want to make sure about is just in terms of communication reports, making sure everybody's copied in. I think paediatricians copy a lot more people in than the adult. So often we just
copy the person who referred, but it's important. The school paediatric team like to know and various other people and everybody at GOSH as well. So it's just sort of understanding that need of multiple specialists in communication, which is slightly different.
These are the different pathways. Yeah. And then
So yes, we've been working with one of the paediatric registrars on developing a qualitative questionnaire for the parents. Obviously, we've started doing the service, but we haven't gotten a lot of feedback from stakeholders. We're making it work within an existing service, so we didn't have a consultation with the local sort of children and their families before setting it up. So it's important that we take their feedback and adapt as we go along. And this is everybody that I can think of, all the people who have helped the service become born.
thank you.
So thank you very much. Thank you.
Thank you so much, guys. We could do with a service like you everywhere, I think. Any questions for these guys?
Thank you so much. That was really good. I just wondered, in terms of your annual review that you offer for them, I guess it's a newly developed service, and I guess you're going to continue to build your caseload. So do you feel that the annual reviews are going to continue, or will that be possible within service demand? And do you have therapy involved as well?
So we have an existing, with the long-term conditions register has been in existence for years. So there's a lot, we already review the patients on that. So it's not a large number of different patients. So it's usually a telephone call from a specialist nurse once a year. Obviously, we can dip in and dip out depending on need. So after the first initial detailed review, we will then, if needed, prescribe a course of therapy. And if that, once that's completed, then I will still be really available. I think at the beginning, they need a lot of reassurance that the neurologist is going to help them. It's not the same. We have to set very clear boundaries. It's not the same as paediatrics. We just don't have the resources. But yes, I think they will automatically either see me in my neurology clinic or get that telephone call, depending on how complex their neurodisability is.
Can I ask
a very good question?
I'm interested to know, I'm in an adult team that receives people who transition, and I see the real trauma that these families go through on transition. So I think it's amazing, this service. If you could wave a magic wand and deliver whatever you wanted to deliver in that service, what would that look like? Rather than a physio, an OT and a neurologist, would you have anything else? Key workers.
Yeah, that's what we need. We need a coordinated care worker, because at the moment that's just falling to us as clinicians, which makes no sense, really.
And we often find we have to do a lot of work with the parents, building them up for kind of allowing their child to take care of their own medical care as well. Do you find that you're having to do that, or is there not capacity to do that?
So I think definitely that's something I'm very comfortable with, I suppose, because I do a lot of rehabilitation. I'm a neuro rehab consultant, so I'm used to sort of helping with that. And often it's never occurred to parents that maybe their child would live alone or do all of these things, because whenever they're a child, they're very dependent, and that does not necessarily mean that's always going to be the case. So it's something I'm comfortable with introducing. But it's not done in one day or one consultation. So, yeah.
So I think you said that you set this up initially without doing lots of PPI, lots of patient and family consultation, but you're now going back to do that. So is there anything that so have you started that process? Are you getting feedback from?
Yeah, so we've developed a questionnaire with the one of the paediatric registrars who's got an interest in questionnaires, and we're about to send that out to the families. That's one way we're doing it.
But have you got do you have any feedback yet to say from them saying, well, you did it wrong? So, I mean, the reason
that is a good question.
The reason I'm asking is I think what you've done is amazing, and it feels like you know what needs to be done, so you've just gone and done it. If you were writing this as a grant, as an NHR grant or Stroke Association, you'd have to do so much PPI and focus groups. They wouldn't, they would make you do it that way, so you can't.
And I think they should, because in a way we've just used what we have, but what we have might not be the best. And so we will have to take time and make sure. So eventually that clinic where I also see people with, spasticity and, long-term disability who I've seen as an inpatient, that will reach capacity and we will have to. And we've been planning towards moving to a separate service. But in order to get that business case, we're going to need to do that, yeah.
You're anticipating any particular comments from that audience?
I sense that they get a lot of, one of the
So
paediatric
delighted that you've
nurses
done it.
phones them to remind them to pick up their children's epilepsy medications, and it's just, that's not going to happen. It can't happen, and I think they will inevitably notice a drop off in intensity, and it's just, there is going to be a little bit of fear around that, I anticipate.
But I think that the fear is lessened, even if it's not completely, it's never going to be the same with paediatrics, but it really goes from 100% to 5%. At least here we're going to 75% or 50%, which is so much better, because they just don't, they really are terrified, and they talk to each other, so they're already anxious before we even discuss transition, because they've already had feedback from other parents about how awful it's been. So, we really have to start at a very low level and build up that relationship. And I think that they just appreciate that there's someone they can call, and there is somebody at the end of the line who knows about cerebral palsy, because otherwise it's the GP. So, it definitely worked. But I personally just think there's been tons of focus groups already, and they all want key workers. That's what they want. So, if we're going to go for funding, that's what every if you look at all the studies, they want their coordinator.
And I have been doing some work on a project looking for a social prescriber in NCL for children and young adults with cerebral palsy. And the disparity from what the person would expect from them, odd jobs and some shopping, as well as fixing your wheelchair, and what that they can provide, there's a big disparity. So I think it is important to ask these questions so we can set clear boundaries, and that's important. Thank you.
Thank you. Great. Thank you so much, Ella and Anna.